Hello, everyone. My name is Christoph Correll. I'm professor of psychiatry and molecular medicine at the Zucker School of Medicine at Hofstra Northwell in New York. And I'm also professor and chair of the Department of Child and Adolescent Psychiatry, Charité University in Berlin, Germany. Welcome to the program addressing positive, negative, and cognitive symptoms of schizophrenia, new and emerging strategies for success. This is my disclosure information that you can review at your own time. And this is the information we want to go through with you, the learning objectives. We want to appraise the clinical utility of new and emerging agents for the treatment of positive, negative, and cognitive symptoms that are associated with schizophrenia, evaluate the safety, efficacy, and indications of novel and emerging long-acting injectable formulations of atypical antipsychotics for the treatment of schizophrenia, and also tailor schizophrenia treatments based on patient and disease characteristics, including shared decision-making and also taking therapeutic response into account. Well, let's get started with burden and pathophysiology of the disease. As you all know from your clinical experience, the burden of schizophrenia is enormous. It has a lot of personal and family burden, and people cannot achieve many of the goals that we take for granted. Going to school, having a job, having friends, having a romantic relationship, having family, spending time meaningfully when people are not at work or when they're not in school. This translates also beyond the humanistic burden into economic burden. And as you can see on the slide, even though patients with schizophrenia are about 0.7% of the general population, they incur an enormous debt to society. In the United States, about 343 billion annual costs, translating into $88,000 roughly per patient per year. Now, what does this cost consist of? There's direct cost, which is a lot of medical cost, about 62 billion, and the direct non-medical health-related costs, about 35 billion. But those 90 billion together are dwarfed by the indirect costs, and indirect costs have to do with the missed opportunity because of the illness. Unemployment, other indirect costs of needing support, homelessness, but also almost half of it is caregiver burden, which we often don't think about. How much does the illness of someone you love, who's in your family, then trickle down as a real burden emotionally, but also financially to the family? So we need to treat the illness as a holistic disease, both in terms of being a brain and a body disease, but also an individual, family, and societal disease. So it's a huge, enormous opportunity to improve outcomes by treating this illness better, identifying it early, getting people into treatment, and trying to achieve with the treatments the best goals for them. Now, what does schizophrenia consist of? What are the areas that interfere with functioning, which is the ultimate goal? Well, we have the traditional classic triad, which is also in the title of this program, and that is positive symptoms, delusions, hallucinations, thought disorder, disorganized behavior. Negative symptoms, the 4 or 5 A's, alogia and affective flattening as the expressive negative symptoms, and then the 3 experiential negative symptoms of amotivation, asociology, and anhedonia. And the third part of the triad is cognitive dysfunction, which really encompasses all of the different cognitive domains that we use as humans. And I'll show some of this later. But in addition to that, we also have motor symptoms that are not just related to dopamine blockade and antipsychotics. We know that there is spontaneous dyskinesia, that people can be catatonic, and we don't want to make that worse by too much dopamine blockade. There's cardiometabolic burden, even independent of antipsychotic use. We know that family members of people with schizophrenia have more diabetes. We know that antipsychotic naive people with schizophrenia actually have dysregulated insulin and glucose systems. We also have affective symptoms, as you know, when that is at least 50% of the illness, and when there's at least 2 weeks lifetime of psychosis without affective symptoms, we can give the diagnosis of schizoaffective disorder. But even when that is not as extensive in terms of affective symptoms, many people with schizophrenia are depressed, about 30% of them. And suicide rates are quite high, between 5 and 10%, particularly in the first 5 years of illness, when patients have to grapple with the fact that they have acute schizophrenia. What's the pharmacologic basis of our current treatments? As you know, it has to be to do with dopamine. Since the first discovery of chlorpromazine as being a major tranquilizer because of its sedating effects, but then being discovered as being an antipsychotic, we now know that postsynaptic dopamine blockade helps psychosis. And actually, the tighter the binding to the dopamine receptor, the lower the dose needed. There's almost a perfect correlation. That has given rise to first and second generation antipsychotics that all in net reduce postsynaptic dopamine flow and transmission, particularly in one area where psychosis resides, and we'll talk about what that is, but also across the brain. Our current treatments are non-selective dopamine blocking agents, and they're either full antagonists, and you need 60 to 80% postsynaptic dopamine blockade to get enough antipsychotic effect without too much dopamine blockade across the board, particularly in the neuromotor pathway, so that we don't get too much EPS. But with partial D2 agonists, we have to have at least 90% or 100% postsynaptic dopamine occupancy because there's a 20 to 30% intrinsic activity, again, getting to a net effect of about 60 to 80% postsynaptic dopamine blockade. So far, so good, but the problem in the brain is restricted to one area. We in the past thought, based on animal models, that there's hyperdopaminergia in the limbic system, the mesolimbic system. This has been revised over the last 7 years. This is true in rodents. It is not true in humans. In humans, actually, there's too little dopamine in the mesocortical pathway, where we think secondary negative, cognitive, and depressive symptoms. There's too little dopamine in the mesolimbic pathway, which has to do with reward, which is why people with schizophrenia also abuse substances. There's too little dopamine in the area of the nigrostriatal pathway sometimes when we have spontaneous dyskinesia, but otherwise it's normal. There's a normal level in the tuber and fundibular pathway where prolactin is being controlled by dopamine, but there's too much dopamine in the nigrostriatal pathway 1, which is the associative striatum. So this striatum has 3 parts: the mesolimbic part, too little dopamine; the sensory motor part, which has to do with motor, most likely the same, normal or a little decreased, but it's really increased in the middle part, in the associative striatum, where a lot of the external and internal stimuli are being integrated. So what do our current antipsychotics do? I already mentioned they're non-selective pan-dopamine post-receptor blockers. So that means, yes, they reduce dopamine tone in the associative striatum. Great, psychosis goes down. But, oh my God, they also reduce it more or less, depending on dose, depending on how much unopposed dopamine blockade there is. They also block it in the areas where we already have too little dopamine, mesolimbic, mesocortical pathway, and they reduce it in areas where the dopamine system should run normally, in the sensory motor pathway and in the pathway that has to do with dopamine. So because of that, we get reliably dose-dependent side effects of dopamine blockade. So wouldn't it be great to actually be selective and only reduce dopamine in the area where it's too high? Wouldn't it be great to not just talk to the postsynaptic dopamine receptor, where we don't think things are so off, but rather have a presynaptic answer to a presynaptic problem where we think there's too much dopamine output in the nigrostriatal pathway. And we'll talk about a possible solution on that end. Now, let's first go through some novel agents that have been approved, followed by emerging treatments. Let's start first with lumateperone. Lumateperone is an atypical antipsychotic. Why this double atypicality? Well, it has certain features that are unique to this second generation antipsychotic. First, it has the tightest 5-HT2A to D2 blockade, so 500%, 600% greater. We know that serotonin 2A stimulation can give you psychotomimetic effects. Psychedelics do that. So maybe having strong blockade on the 5-HT2A receptor can help with antipsychotic effect. We know that pimavanserin, which is a 5-HT2A inverse agonist antagonist, actually is an antipsychotic, at least in the context of Parkinson's disease. The second atypicality is that lumateperone is a presynaptic partial agonist stimulating the autoreceptor, which is the brake in the system, but a postsynaptic antagonist. All other drugs do the same. They either block the brake and the gas pedal. That's antipsychotics as dopamine blockers. So that means they can increase some presynaptic dopamine, or they're partial agonists pre and postsynaptically. They block a little bit the presynaptic side by stimulating the brake, but they also stimulate the gas pedal. So lumateperone doing the right thing presynaptically, stimulating the autoreceptor, downtoning dopamine, and putting the foot on the brake, gets away with 39% of postsynaptic dopamine blockade. Remember, I told you it needs 60 to 80%. Here, 39%, which is like clozapine in the PET study. And that gives us almost no postsynaptic dopamine blockade related side effects because of this little blockade or little occupancy of postsynaptic dopamine receptors. The third atypicality is that at the same nanomolar concentration that dopamine is blocked, lumateperone is an SSRI, a selective serotonin reuptake inhibitor. So it has antidepressant activity built in. And the fourth atypicality is it's a D1, dopamine receptor D1 related agonist, which then translates into NMDA and AMPA, glutamatergic drive, which is increased, which can help potentially negative and cognitive symptoms, have not been tested, but it makes it a very rapid acting antidepressant. And as you know, lumateperone is already approved for bipolar depression, has data that are positive in unipolar depression under review with the FDA, and is studied right now also for mania. So that's lumateperone, first study against placebo, 42 milligrams worked similarly well as risperidone, 4 milligrams with an effect size of 0.4. Then in the first phase 3 study, again, significance of 42 milligrams, which is the approved dose for total symptoms, positive symptoms, and clinical global impression scale. The 28 milligram dose didn't separate on total PANSS, but did separate on positive symptoms and on CGI. Maybe it didn't cash in on all of the items on the general PANSS psychopathology subscale because lumateperone has very few side effects. In fact, only 2 are greater than placebo and at least twice the rate, and that is one is dry mouth, which is very low, and the other one is sedation, 20 to 24% versus 10% on placebo. But that was when lumateperone was given in the morning. When it was given at night, which is now recommended, it's down to 10%. There was no greater risk than placebo for weight gain, for metabolic abnormalities, no prolactin elevation. So it's currently one of the safest atypical antipsychotics that we have. The next approved drug is Olanzapine in combination with samidorphan. What is samidorphan? Samidorphan is a mu-preferring opioid receptor antagonist. Why would we want to fiddle around with the opioid system when giving Olanzapine. Well, olanzapine is a very potent and good antipsychotic, but it has one Achilles heel, we all know it, and that's the cardiometabolic burden, particularly through weight gain. Now, when we eat, we reinforce food intake by having the opioid system light up. We enjoy food, we eat more of it by having samidorphan, the mu-opioid receptor antagonist. After a lag time of about 3 to 4 weeks, there's no further weight gain. That's almost a flat line. So for the first 4 weeks, the weight gain is very similar, as can be seen on the slide, like olanzapine alone, but then it separates. And while olanzapine keeps going with weight gain, olanzapine samidorphan flattens out. And even when you then go from the acute study, which is on top, 12-week study, phase 2, to the 6-month open label extension, the dark line that was going up and up and up switched over to olanzapine samidorphan, became a flat line too. Now this was phase 2. Then the FDA said, show us that giving a centrally active drug, samidorphan, with olanzapine doesn't detract from olanzapine's antipsychotic efficacy. 4-week study, check, same effect for psychosis, better than placebo, whether you have olanzapine alone or olanzapine with samidorphan. The second task was to show that not at 12 weeks, but at 6 months, samidorphan added to olanzapine leads to less percent weight increase, less people gaining at least 10% of weight. And that was shown also. Although olanzapine plus samidorphan was not free of weight gain, it clearly had 40% less percent weight gain, 4 versus almost 6.6%, 3 kilograms versus 5 kilograms at 6 months, about 18% gained at least 10% versus 30%, and 7% weight gain and about 28 versus 43%. So it's not zero, but we're cutting the odds in half for gaining 10% or 7%, having at least 5 centimeter waist increase, which is recognized as a problem of adiposity, which translates into bad cardiovascular outcomes. And we're also showing in a sub-analysis of people free of hypertension, free of metabolic syndrome, that we were able to reduce the incidence of those 2 adverse outcomes over 6 months in people receiving olanzapine samidorphan versus olanzapine alone. In terms of side effects, this is olanzapine without the much weight gain. So no other surprises. And that combination is approved by the FDA, both for schizophrenia and for bipolar I disorder, based on the data in schizophrenia. But the revolution that has happened in schizophrenia care in terms of pharmacology comes currently from the muscarinic system. Now, the muscarinic system we've thought about for a long time only as a side effect problem, the cholinergic system. Too much anticholinergic effects can give you dry mouth, concentration difficulties, and we need an anticholinergic to counter extrapyramidal side effects when we can't go down on the dose or switch the medication. We're now talking about a very different approach to the cholinergic system. We want to actually agonize, increase the muscarinic tone. And there are different receptors we can talk about. And what's interesting to consider is that the revolutions currently occurring in psychiatry are with mechanisms of action we've known for decades, if not hundreds of years. In depression, it's 5-HT2A agonism, so the psychedelics. It's NMDA antagonism, the ketamine effect. And in schizophrenia, it's actually the pro-muscarinic effect. And you may not know it, but in 1959, around the time when chlorpromazine was discovered, there was a study with arecolin, which is a betel nut derivative, and showed antipsychotic effects. But people had a lot of peripheral procholinergic side effects, nausea, vomiting, and also syncope. Then Eli Lilly studied Xanomeline alone, without a combination and without titration, in people with Alzheimer's disease in a 6-month study targeting cognition, because M1 receptors reside in the frontal lobe, and by increasing cholinergic tone, agonizing muscarinic receptors increases acetylcholine drive. The hope was that cognition would improve, and it did. People had better cognition on Xanomeline in Alzheimer's disease over a 6-month study. But even more so, with a bigger effect size, there was an antipsychotic and an anti-agitation effect. Wow, we now had a pro-cognitive, antipsychotic, anti-agitation medication. Why is that not approved? That was 1997. Because without peripheral countering of the procholinergic side effects, without titration, there were so many side effects: nausea, vomiting, syncope. So this was shelved. In 2008, a small study, 10 versus 10 patients with schizophrenia, showed again that Xanomeline alone, without titration, was better than placebo for cognition and psychosis, 10 versus 10 patients. But again, 70% had gastrointestinal side effects. So it took another 12 years or so until someone came up with the idea, well, maybe we should pair the procholinergic effect that we want centrally with a peripherally restricted anticholinergic to make Xanomeline trospium, the first non-postsynaptic dopamine blocker approved for schizophrenia since September 26, 2024. Now, what does Xanomeline trospium do? First, let's introduce the cholinergic system. So the cholinergic system comes as nicotinic receptors that are ion-gated channel receptors. They are fast. They also downregulate fast. That's why giving a nicotine patch doesn't help cognition. The receptors downregulate. We'll not talk about the nicotinic system. Let's talk about the muscarinic system. These are G-protein coupled receptors that have a second messenger cascade below them. And they also innervate peripheral organs. The muscarinic system comes in 5 receptors. We have the odd-numbered 1, 3, and 5. They are postsynaptic receptors. When you stimulate them, it's a go. Postsynaptic receptors stimulation, cholinergic system lights up. We have the even-numbered 2 and 4, and they're presynaptic autoreceptors. When you stimulate them, you stimulate the brake, it's a stop. Okay? M1, a go, M2, a stop by stimulating them. We also need to understand the idea of orthosteric agonists. There's a pocket in the receptor where the usual neurotransmitter goes. When you sit there, you either sit on the gas pedal, if you're a stimulant of it, or you're a blocker. But there's also an allosteric side that's to the side, and that governs the tightness of binding of the endogenous neurotransmitter and also transmission. So when you have an allosteric agonist on the muscarinic system, binding of acetylcholine is stronger and transmission goes up. This is preserved in terms of locality and also timing of physiologic transmission, whereas agonism just puts the foot on the gas pedal the whole time. Now, how do we understand the antipsychotic effect of muscarinic agonists? Let's first talk about the bottom-up and then the top-down antipsychotic effect. Bottom-up has to do with the M4 agonism or M4 allosteric positive modulation. There is a transmission of the cholinergic system from the hindbrain to the midbrain. And in the midbrain, if we have too much acetylcholine, we have more output on the dopamine system. Acetylcholine and dopamine are friends. That means by stimulating M4, an autoreceptor, we're reducing the transmission of acetylcholine and the effect on midbrain dopamine. By reducing midbrain dopamine, we have less output of dopamine in the associative striatum. At the same time, there's an M4 receptor locally in the associative striatum on a cholinergic interneuron. And by stimulating M4 there, again, presynaptic autoreceptor, we're again decreasing acetylcholine. And locally, that also reduces the dopamine output in the associative striatum. Now, by reducing acetylcholine via stimulation of M4, the autoreceptor, if that were happening in the sensory motor striatum, we would have EPS. But that is governed by M2 and not M4. So M4 is very specific for that part of the striatum where psychosis resides, which is why M4 agonism, decreasing acetylcholine, decreasing dopamine presynaptically, works for psychosis. Now, where does M1 come in? I already told you M1 sits in the frontal lobe in the cortical area, not subcortical. By stimulating M1, which is a go, you're increasing acetylcholine in the frontal lobe, and that increases glutamate and dopamine, and you think better. You light up. But we also have a glutamatergic input into the midbrain, where we think there's an EI imbalance in schizophrenia. Too little inhibition, GABA, too much glutamate into the midbrain. So both acetylcholine in the midbrain is bad, and glutamate in the midbrain is bad. So what happens when we stimulate M1 downwards, top down? The M1 receptor sits again on an interneuron, a GABA interneuron. GABA is the brake in the system. By stimulating the brake, we're decreasing glutamate input into the midbrain and decrease dopamine output. Wow, isn't that interesting? We're now not talking one receptor, one medication. It's actually crosstalk across multiple neurotransmitter systems. Via M1, M4, we decrease cholinergic drive, we decrease dopamine. Via M1, we increase GABA, we decrease glutamate, we decrease dopamine. With that, most likely there's better balancing because it's not just one neurotransmitter system. They all talk to each other. Now, this is all brain talk. What does it mean for the patient? Here you see a summary of 3 studies that led to FDA approval of the first non-postsynaptic antidopaminergic drug, the first muscarinic modulator, Xanomeline trospium. Xanomeline being an M1/M4 agonist with the peripherally restricted pancholinergic antagonist trospium to buffer peripheral procholinergic side effects that have to do with the GI system. And here you see pulled together in 3 5-week studies, very nice and robust reduction in total symptoms, in positive symptoms, and in 2 studies also in negative symptoms. This was very robust across different subgroups. Looking at side effects, though, there are both pro and anticholinergic side effects. 18.5% have nausea, about 14% have vomiting. Those are procholinergic side effects. Also, we have constipation, which is an anticholinergic side effect of 17%. We have dyspepsia because there's a slowing of the food going through the stomach, again, an anticholinergic side effects. These are not minimal, but we've shown in a sub-analysis that most of these symptoms occur in the first 2 weeks, and then they're gone by week 3. And you can see that overall discontinuation due to side effects in these inpatient studies, so nurses were around, was only 1% more. 5.6% stopped antipsychotic or KarXT treatment, Xanomeline trospium, because of side effects versus 4.7%. How is this medication dosed? It's BID dosing, and you start at 50 milligrams Xanomeline, 20 trospium for 2 days. Then you have another 5 days of 100 milligrams Xanomeline, 20 milligrams trospium, and then by day 8, you graduate to 125 milligrams Xanomeline, 30 milligrams trospium, always twice a day. And it has to be without food, 1 hour before food or 2 hours after food, because with food, the trospium is not absorbed well, and then you may have more side effects. The efficacy should be the same, though. But you see that despite being an antipsychotic, we have none of the usual antipsychotic side effects that are related to dopamine blockade. No prolactin elevation, no extrapyramidal side effects. We have no weight gain, no metabolic abnormalities, and also no sedation or insomnia. This is a meta-analysis we did showing again that the side effects do occur, gastrointestinal, pro and anticholinergic, and that this effect sizes are really remarkable. 0.56 for total symptoms, which is similar to olanzapine in meta-analyses, 0.59 for positive symptoms, and 0.33 for the non-select negative symptoms that were not selected here. And remember, 0.2 is a small effect size, 0.5 is medium, and 0.8 is large. There was recently a press release about the ARISE program, which was the attempt to have Xanomeline trospium, a presynaptic modulator, added to antipsychotics, as we now know them, that are insufficiently working, so residual positive symptoms. Here, there was a much longer duration before the titration went up. So it's now a week of 50-20 Xanomeline trospium and week of 75-20, which was not as an intermediate group, always BID given in the original study, then 120 for the third week. And only by week 4 was 125 Xanomeline, 30 milligrams trospium twice a day reached. So they only had really 2 weeks of full dose, and for people with residual symptoms. So it may not have been long enough at a high dose, may not have been long enough to begin with. And what was press released is that overall, on the primary endpoint, Xanomeline trospium added to antipsychotics didn't separate from placebo added to antipsychotics, but there was an effect in the subgroup of non-risperidone treated patients. So we need to understand more about these combinations. Another treatment, which was an M4 positive allosteric modulator, emraclidine, worked in a phase 1b study. 27 patients on 20 milligrams twice a day, 27 patients on 30 milligrams once a day, worked against 27 patients on placebo with effect sizes of 0.59 and 0.68, enormous. But the big studies didn't show the same effect. There was no statistically significant superiority, but the placebo effect enormously increased and the drug effect went a little bit down. So we need to understand more whether M4 alone works, whether positive allosteric modulation works as well as the full agonism. We will see over years many more of these agents come to market. These are robust effects for psychosis, but most likely also other conditions where we have too much presynaptic dopamine. Emraclidine is the M4 positive allosteric modulator I mentioned that had one positive study. There is a neurocrine agent, 568 it's called. It's an M4 full agonist, also has positive data for 20 milligrams, not for the higher doses is being pursued. And you can see here other agents either adding sigma-1 agonism to M1 agonism, which may help negative and cognitive symptoms, having MapLight 007, another M1, M4 agent that is paired again with a peripheral anticholinergic. And we will see many more of these agents that are being tested, hopefully come to market and enrich our armamentarium. There are two other agents I want to mention. One is amisulpride, that is methylated as LB-102. Those that have worked in Europe or read the literature know that amisulpride comes up in meta-analyses quite high in terms of efficacy, even higher than olanzapine, but has never been brought to the United States. It's the only benzamide antipsychotic. The problem is it doesn't penetrate the blood-brain barrier very well. That means you need 600 to 800 milligrams of amisulpride to have antipsychotic effect. A lot is outside of the blood-brain barrier, so you can get QTC prolongation and prolactin elevation. The methylation of amisulpride, making it an LB-102, preserves the D2-D3 antagonism and 5-HT7 antagonism, but gets away with 50 to 100 milligrams for antipsychotic efficacy, thereby reducing the amisulpride component outside of the blood-brain barrier, making less significant peripheral side effects as a result. And we also know that at low doses, amisulpride, through the 5-HT7 antagonism, has been shown to be an antidepressant and work for negative symptoms. So here we have LB-102 as a potential new agent to help for positive symptoms, but also potentially negative symptoms and depression. And there's Evanamide, which is the first studied state-dependent inhibitor of voltage-gated sodium channels. And via this voltage-gated sodium channel inhibition, you reduce glutamate tone, but not at baseline where we need it, only when it's overshooting and firing. And with that, I told you before that glutamate input in the midbrain increases presynaptic dopamine output. There's the hope that hyperdopaminergia in the striatum can be reduced. And this is currently studied for treatment-resistant cases. So not like the ARISE study where KarXT was added to ongoing antipsychotics for residual positive symptoms, but rather here for really treatment-resistant patients, either on clozapine or not on clozapine, including 2 antipsychotics. And in initial study, there was a positive effect, which is now followed up in a phase 3 program. Side effects were very limited with Evanamide, which obviously would be wonderful to have an alternative to clozapine without such big side effect burden like clozapine and no blood work needed. Let's go to antipsychotics of the long-acting. And we use long-acting injectables because people do stop medications. Here we have a study from Finland showing that females were more likely to stop, younger patients, those that were shorter in the hospital, and also substance use patients. But LAIs were better than oral treatment. And we showed that also in a meta-analysis of 137 studies and almost 400,000 patients, that whatever design you looked at, randomized trials, cohort studies, or pre-post or mirror image studies, the LAI version of an antipsychotic was superior to oral treatments for hospitalization and relapse by prolonging medication adherence and also having lots of functional and other positive outcomes. So what are some of the new developments in the LAI, long-acting injectable world? First, we now have Paliperidone, not just as 1 monthly, but also 3 and even 6 monthly, twice a year injection. And this slide shows the non-inferiority, the similarity, whether you give 3 monthly, 4 injections, or biannually, 2 injections. There were no increased side effects. The medication is released in a very controlled fashion. This is deep intramuscular, and you need to come via the 1 or 3 monthly to the 6 monthly. The next innovation is subcutaneous long-acting injectables. This is TV46000, which is Risperidone, either 1 monthly or 2 monthly, injected either in the abdominal subcutaneous fat or in the back of the arm. And that was significantly better than placebo in this relapse prevention study, subcutaneous long-acting Risperidone, with blood levels that are achieved within a day, without booster injection, without oral co-treatment, and without a loading dose. In terms of side effects, this is Risperidone, which we all know very well. No surprises there, just less peak trough variation with a subcutaneous version. The next innovation is Olanzapine as a long-acting injectable subcutaneous drug. Why is that relevant, particularly for Olanzapine? Well, you may know that the deep intramuscular Olanzapine palmoate, 2 weekly or 1 monthly injection, actually has the problem that when you lacerate a blood vessel, all of this very blood-soluble medication can enter the bloodstream. And there's a lot of sedation, and that's called the post-injection delirium sedation syndrome. That can even lead to stop breathing, and people may need to be ambubagged. So in that sense, we need 3 hours of post-injection observation, which is hard to do, which is why deep intramuscular Olanzapine injection is not used much. By Turning this into a subcutaneous version, and the subcutaneous fat is very little vascularized, there is very little risk of PDSS. Plus, as I will show you on the next slide, even when you inject it into the blood or water, it creates basically an aggregate so that it doesn't flood the bloodstream. This is the 8-week study that the FDA wanted. It wasn't a relapse prevention study. Show us that the subcutaneous version of olanzapine works. And in all 3 doses that are equivalent to 10, 15, and 20 milligrams of olanzapine oral, there was significant reduction in symptoms compared to placebo. And this is olanzapine as we know it. No surprises. There can be weight gain and metabolic abnormalities, but other than that, very well tolerated. And this is showing you when olanzapine enters the bloodstream, almost 100% is released and absorbed, whereas even when the subcutaneously injected polymer then forms, you get less than 20% entering the bloodstream. But we don't even think that there is a risk of laceration. And there have been more than 4,000 injections in the open label extension study of the Solaris trial without any PDSS. Now let's talk briefly about negative symptoms. Negative symptoms are currently unaddressed by the treatments we have. I mentioned there is the expressive and the experiential part of it. There are different ways to measure it. We should measure it maybe with a short version, but also observe patients and ask what they've done in the past. We have, for example, the NSA-4, which has to do with observing the speech quantity for alogia, the reduced affective variation, and then also social drive. How much have people met with others, and was it by their own account or were they dragged along? And also, what is their interest level? And that can be easily assessed in order to know where patients are. Although nothing is approved right now for the treatment of negative symptoms, we want to reduce secondary negative symptoms in schizophrenia. That means treat conditions that can mimic negative symptoms: depression, dementia, social anxiety, substance use, and even ongoing positive symptoms where people may withdraw due to the psychotic experiences. Make sure people don't have extrapyramidal symptoms or sedation, which can downtone the entire system and may also impose like negative symptoms. Ask about interrupted breathing and snoring, because when there is not enough oxygenation during sleep, when people have sleep apnea, they cannot function well during the day, and it may look like negative symptoms, as does chronic pain and social withdrawal due to stigmatization and environmental deprivation. In terms of treatments that separate from comparisons for people with predominant negative symptoms, meaning few positive symptoms left, we have amisulpride at low doses. I mentioned it, 50 to 300 milligrams with the non-methylated version that's available in Europe, but also cariprazine being superior at 3 to 6 milligrams with a median dose of 4.5 versus risperidone. And then olanzapine was superior to risperidone, but that is due to the risperidone effects that obviously dampen the dopamine system. Looking at augmentation strategies, it seems when you add a partial D2 agonist, and in the meta-analysis we did, it was only aripiprazole, to an antagonist, you can reduce negative symptoms, whether that is bumping off the dopamine blocker and reducing secondary negative symptoms or improving primary negative symptoms is unclear. We also know that antidepressants added to people with schizophrenia who are on antipsychotics, even when they say they're not depressed, can improve negative symptoms, particularly noradrenergic acting antidepressants, like, for example, mirtazapine. But there's also the possibility that Xanomeline trospium, via the stimulation of the M1 receptor in the frontal lobe, can create output of acetylcholine and dopamine. And here, at least in the enriched population with more negative symptoms and in the pooled analysis, it seemed that there was an improvement in negative symptoms. However, we have to take this with a grain of salt because patients also improved positive symptoms, and there could be pseudospecificity. Let's move to the third dimension, which is cognition. And here you can see with the size of the bubbles that schizophrenia really is the most pan-cognitive disease because it has the biggest size of the bubbles across all or almost all of the cognitive domains, even more domains than in Alzheimer's dementia, which is quite remarkable, but shows also how much need there is to improve cognition in people with schizophrenia. Cognition is a black box. We don't really assess that well in clinical care. The MoCA or the mini mental status exam doesn't really give us fine-grained enough assessment of cognition. It's too crude. It's really for dementia. But when looking at the 7 domains of the matrix battery, also measured with other cognitive batteries like the BACS, the brief assessment of cognition in schizophrenia, or the BINS or the CANES or other assessments, which we will look at in a minute, we can see that we can actually assess those in real-world settings by asking the right questions. So for attention, for example, ask your patient whether they're able to read a book or pay attention to a movie. When people only watch little clips of 20 minutes or so, maybe that tells you they can't hold the whole story. Or when people start reading the newspaper and at the end of a paragraph have to always go up again. What about working memory? Can you keep a number in mind without looking always at the piece of paper again? Verbal learning. Your partner told you to bring 6 items from the store. You forgot your piece of paper and you only bring back 2 because you can't keep these items in your mind. Verbal learning, that's also visual learning and memory. Misplacing keys, not knowing where your car is. That can also lead to hallucinations, to at least delusions, when you think you put something somewhere and then you can't remember it. Very common in Alzheimer's disease. Someone stole the money and you don't remember anymore where you put it. Problem solving and reasoning. Well, when something happens and interrupts the routine, can you shift? Take another road to the hospital to see your doctor, or are you just very set in your ways? Speed of processing, how quickly can you type? But social cognition arguably makes us human. Can we anticipate what other people think when they say something, what they expect of us? And this mismatch of the social adaptation and expectation and reading of the mind of others is something that also makes communication in people with schizophrenia difficult. Here are some of the assessment batteries. The problem is they take too long. They are not yet adaptable to usual clinical care, which is why those questions and areas I just went through are very useful in order to understand whether people have cognitive difficulties. Do you sometimes feel you're off in a conversation? You don't get what people want to tell you. But you can also use some of these in research that we're looking at here, those measurements of cognition. If and when another medication becomes available for cognition, it's very important that we get bedside tests for measuring cognition, both at baseline and improvement. Here's the most recent meta-analysis from 2025 looking at the effect of antipsychotics on cognition. And although it looks like, yes, some seem to do something, when you go from the left unselected sample to the right, only people who don't have residual positive symptoms that by improving can cause pseudo improvement in cognition, then you see nothing is better than the control. So our current antipsychotics don't improve cognition. Some can make it worse with too much EPS or with too much problems in sedation and other areas. The glutamate receptor system has been very much implicated in cognition. We've tried with multiple approaches to increase NMDA, glutamatergic drive. NMDA, glutamate receptors play a role in cognition, but the problem is glutamate can be neurotoxic, so you can't give glutamate. So we've tried to increase the co-agonist either glycine, by glycine transporter inhibitors like bitopertin in the past, or now iclepertin very recently, or by stopping the breakdown of D-serine, another coagonist, via blockade of the D-amino acid oxidase, and that's, for example, luvadaxistat. All of these approaches ultimately were negative, and we do not have anything yet approved for cognition. There are different agents currently under investigation, including RL-007, which has a triple mechanism. It's a GABA B receptor agonist, it's an NMDA receptor agonist, and a nicotinic receptor, again, another cholinergic system modulator agonist. So maybe with this triple mechanism, there is some hope in this multi-determined cognitive ability. But KarXT, Xanomeline trospium, which is approved for psychosis, also has data in the acute studies, at least, for improving cognition. At least in the 50% of patients who had at least one standard deviation of cognitive disability below the norm, where the effect size was about 0.5, and the improvement did not seem to be related to improvement in total symptoms or positive symptoms. However, there could still be pseudospecificity. We do need studies in patients who are stable in terms of positive symptoms to see whether there's an independent effect on cognition. Let me go to tailoring treatment options. We need to have a team approach. We can't do it all alone. We need to set priorities and goals, appraise patients' strengths, select appropriate interventions, but also determine both internal and external resources for the patient. We need to clarify personal choices, identify environmental options, clarify values, and identify personal interests. Why? To make goals pertinent, to map goals toward the treatment that we think makes the most sense for the patient. By doing so, we also want shared decision-making, but do not share the decision with the illness. I don't want to take the medication. Oh, that's fine. Come back when you had your next relapse and maybe got into trouble with the law or even hurt yourself or others. No, we want to share the decision with someone who makes a decision in an informed way. So we as healthcare professionals provide knowledge, inquire about preferences, and share insights about options. But people with lived experience should share their experience and values. We need to give them the time, voicing their concerns and asking questions so that there could be a mutual understanding what makes the most sense for the patient. Motivational decision-making and motivational interviewing are huge tools to map medical goals with personal goals. Not talking about we need to treat your illness. Often patients don't even agree that they have that illness. Let's talk about the goals you want to achieve and maybe some of the symptoms you've had that interfere with those goals. And by keeping those symptoms in check, maybe you can achieve your goals even better. So tailoring treatments means to take into account drug-drug interactions and contraindications of treatments, know about metabolic and medical comorbidities we don't want to make worse, know about psychiatric comorbidities that can interfere with treatment success, particularly substance use, but also anxiety and depression that are very common in people with schizophrenia. Identify and address non-adherence. And the only way to know who is becoming non-adherent when is when they don't return to their long-acting injection. So that's a tool also to differentiate pseudo-resistance from true resistance, knowing whether a patient doesn't respond because they do not take the medication as prescribed. And we need to have collaborative as well as measurement-based care as much as possible. To talk about novel treatments, we need to collaborate, educate, communicate, explain, and then have the medication be started. All of this can be done in a very seamless way, and often we need to also involve caregivers. Often we need to give people written documents to take home or websites to print something out or look at, because it goes above their head when so much information is given at the same time. Things need to be reviewed again and explained. But measurement-based care is very important. And we just developed the TGI, the Clinical Global Impression Scale, the Transdiagnostic Global Impression Scale, where we currently have the psychopathology component, 10 symptoms, 5 that are hyper or 5 that are hypo. And you can see on the right-hand side that we can have these spider webs and see how these different symptoms improve or worsen over time. And we also develop this right now for functioning, satisfaction with care, and side effects, all on the same scale from 1 to 7, like the Clinical Global Impression Scale. Let me finish up with a brief case presentation to bring this to light. This is a 21-year-old male, 18 months ago was acutely psychotic, paranoid, his thoughts could be read, cameras were installed, voices were cursing at him. Lower level of psychosis for 7 months, smoking cannabis before he came to care, chilling out to calm his anxiety. He needed an inpatient admission, was diagnosed with schizophrenia, which then was subsequently managed in outpatient care. During the hospitalization, aripiprazole up to 25 milligrams was tried, didn't seem to work for his agitation and positive symptoms. That was followed right away with Olanzapine, up to 20 milligrams to get him discharged quickly. Significant reduction of positive symptoms and agitation. But as we all know from our own treatment of patients, there was quite a bit of weight gain, metabolic dysfunction, and the patient also experienced blunted affect, cognitive slowing due to the sedation. He complained about that, was switched to Risperidone up to 4 milligrams, but experienced hyperprolactinemia, had some erectile dysfunction that he didn't even disclose first and had to be asked about. Still feeling dull and in a brain fog. He gradually had a return on paranoid ideas and mild hallucinations because the side effects made him intermittently non-adherent. He did remain engaged though in outpatient care because his parents reinforced that, and he did not want to go really back to the hospital at all. So here, the strategy was, let's try something new. You didn't really agree with 3 different medications. 1 didn't work so well, 2 did, but had side effects. Let's take the side effects out of the game and try to maintain the antipsychotic efficacy. So Xanomeline trospium with a cross-taper strategy was introduced because he refused further dopamine receptor blocking agents. Here, a slower titration than was done in the inpatient studies was done, 50-20 for BID for 1 week. Risperidone was reduced from 4 to 2 milligrams. Then 1 week of 100 milligrams Xanomeline 20 trospium twice a day, maintenance of risperidone. And by week 3, the high dose 125-30 BID was given and risperidone was discontinued. The side effects, there was mild nausea in the morning for the first 2 weeks, but that resolved also after the dosing was really strictly enforced 1 hour before meals. And by 4 weeks, he had improved positive symptoms, greater emotional expressiveness and focus, and he already started losing some weight. There were no extrapyramidal side effects, prolactin or metabolic effects, and he improved further over time. So let me finish with key takeaways. Schizophrenia is a severe, often chronic and debilitating illness. Very unfortunate for many people who have this illness. Postsynaptic, relatively unselective dopamine receptor blockade has been a mainstay of treatment for 7 decades. Outcomes are mixed for symptoms, more problematic for remission, and even more so for recovery, and nothing is approved for negative and cognitive symptoms of schizophrenia. Non-adherence is the major preventable mediator of poor outcomes, making the early offering of long-acting injectable treatments a very valuable strategy. And we have now new treatments. Currently, no pharmacologic treatment for cognition and negative symptoms, I already talked about, but novel mechanism of action treatments, including muscarinic agonists, may be more targeted, reducing off-target central adverse effects, and may potentially address even beyond positive symptoms, other domains, maybe cognition, and we're waiting for new treatment options like maybe the methylated amisulpride, LB102, or Evanamide to treat further patients and have them experience better outcomes. Clearly, medications need to be paired with pharmacologic and non-pharmacologic treatments addressing schizophrenia and comorbidities. And to achieve all of that, we need collaborative and measurement-based care that has the potential for enhancing outcomes. Thank you for your attention, and I hope that this was helpful for the care of your patients.